All right. This is a practice rehearsal of a presentation for ISDM 2026. Legal mandates for shared decision making and patient decision aids, U.S. policy and implementation. I'm Thaddeus Pope. I have nothing to disclose. This is based on this article, Medicare Mandates for Shared Decision Making with Patient Decision Aids, Linking Payment to Preference. So it's really great to be with you here at Dartmouth. But when I come to these conferences, I get a little bit sad. And that's because when we talk about implementation and adoption of shared decision making, we are often using adjectives like seldom, incomplete, infrequent, stagnant, elusive, and rare. And in the literature that measures implementation, we see there's a significant and sustained adoption problem. Shared decision making is not incorporated into mainstream care. Few clinicians use decision aids. So that's not good, not good. But I get a little perked up, a little optimistic when I hear about Medicare, right? Medicare, the biggest insurer of all, insures 70 million people. And Medicare issued 4 categorical mandates telling clinicians you must use shared decision making and patient decision aids for these 4 procedures. The patient must receive a shared decision making visit, and that must be with 1 or more decision aids. So these are legal mandates. There are other procedures where CMS strongly encourages shared decision making, but we're going to talk about legal mandates for shared decision making. So to not follow these is Medicare fraud, and that's a big deal. It entails a fine, a penalty of $30,000 per violation, and that can add up, right? Let's say you do 6 lung cancer screenings a month without shared decision making. At the end of the year, your fine is going to be $2 million. So this is real consequential law. But there is widespread noncompliance. So let's look at these 4 mandates. Low dose CT scans. This is a lung cancer screening. Are patients who are getting the low dose CT scan, are they getting shared decision making with a patient decision aid? Mostly, no. No, they're not. We started measuring this back in 2018. So the first studies found a compliance rate of 0%. 0. Another study from 2018, 0%. In 2019, 9%. In 2021, 8%. In another study from 2021, 31%. Okay, so that's getting better. Still, most patients aren't getting shared decision making. In 2022, 42%. But that study also noted that a lot of that shared decision making was missing some of the required elements. So the real rate was probably just 21%. In 2023, 25%, and in 2025, 10%. So we have these 8 different measures of adoption of shared decision making, and they're all terrible. More than 10 years after the mandate, the highest compliance rate we ever got was just 31%. So that's just binary, right? That's a binary. Are you doing it? Are you not? In the literature on shared decision making for lung cancer screening, we see that there's a significant rate of people using outdated decision aids that don't comply with HIPDAS criteria, and other problems. So the real or net compliance rate is even lower. With left atrial appendage closure therapy, this is a device to stop blood clots as an alternative to medication. Even at this same conference, we've had presentations about low compliance. This year, we had this study, which put compliance at 75%, surprisingly high. But that is self-reported data, and other studies measuring this find an almost a 40% non-compliance rate, meaning the shared decision-making is not done in the way that it was supposed to be done. With implanted cardioverter defibrillators, a little device to shock your heart back, here studies have found a 43% compliance rate. But again, that's self-reported data. And again, even those same authors found a more than 50% non-compliance rate with the actual elements of shared decision-making. So the net compliance there is probably just 21%. So that's a 79% fail rate. With carotid artery stenting, this is a newer mandate. It's only from 2023, so we haven't studied it as much. But some of the early research from just this year finds compliance is just as bad. So to recap, we get an F grade for all 4 mandates. For a long time, we were wandering through the desert looking for some kind of incentive, some kind of legislation, something to prompt adoption and implementation of shared decision-making. And then these Medicare mandates came along. Oh, it's like an oasis in the desert, finally. Turns out to be a mirage. So what's next? We need to enforce these mandates. To not follow them is Medicare fraud. Take the ICDs, for example. You can't give a patient an ICD if they've had a recent heart attack. But some clinicians did that. They gave ICDs to patients with recent heart attacks. The U.S. Department of Justice prosecuted them, fined them $250 million. We need to issue the same kinds of penalties when clinicians give ICDs or any of these other procedures without shared decision-making. Otherwise, these mandates are just a paper tiger. So, treatment must be clinically indicated before we provide it and bill Medicare for it. Clinicians go to jail every day of the week for not doing that. Treatment must also be preference indicated. And we should treat that at just the same way, because preference indication is just as important as clinical indication. Thank you.